Well, hello everybody, and welcome yet to another segment of Nessa's Diary. And in today's segment, we're going to be looking at preeclampsia, which is a topic in IRH. So in today's segment, we're looking at preeclampsia. And so what are our objectives as we look into preeclampsia? So our objectives are as follows. We're going to be defining what preeclampsia is and understand its significance in maternal health. We're going to explain the pathophysiology of preeclampsia. We're going to be identifying the risk factors and the clinical manifestations of preeclampsia. We're going to discuss the diagnostic criteria of preeclampsia, outline the management strategies of preeclampsia, including the nursing management. And then we are going to review some complications of preeclampsia. So we'll first dive into the introduction. We'll define preeclampsia as preeclampsia is the hypertensive disorder specific to pregnancy occurring after the 20th week of gestation, characterized by proteinuria and hypertension. So by definition, preeclampsia is a hypertensive disorder which is specific to pregnancy occurring after 20th week of gestation and is characterized by proteinuria and hypertension. So the epidemiology incidences of 5 to 8% occurring in pregnancy globally. This is more common in first pregnancies. It has a higher risk in developing countries. So major cause of preterm delivery. So preeclampsia is a major cause of preterm delivery. So what are our risk factors? So some of the risk factors we have in line with preeclampsia is that prime gravidas, which are first pregnancies. So women who are experiencing their first pregnancies have a higher risk of having preeclampsia. So multiple pregnancies such as twins, triplets, quadruplets. So multiple pregnancies also stand a higher risk of having preeclampsia. And then history of having had a close relative who has had preeclampsia before, you also stand a chance to have preeclampsia. And then a family or history of chronic hypertension. So people who have a history of chronic hypertension or people who have chronic hypertension stand a risk of having preeclampsia. Another risk factor we're going to discuss is obesity. So people who are obese have a stand a risk of having preeclampsia. And then diabetic mellitus women also have a risk of having preeclampsia. Even maternal age, women who are below the age of 18 or women who are pregnant women who are above 35 years of age stand the risk of having preeclampsia. Even having autoimmune diseases such as HIV and lupus can predispose someone to have preeclampsia. And then we'll dive into the pathophysiology of preeclampsia. So looking at the pathophysiology of preeclampsia, so normally preeclampsia is coming about due to a hypertension and is occurring in pregnant women during their 20th week, after 20 week of gestation. So what happens is normally the placenta, or normally the blood vessels in the placenta, they develop to allow a lot of blood to flow from the mother to the baby. So when these blood vessels develop to allow a lot of blood flow from the mother to the baby, So now in preeclampsia, what happens is that the blood vessels, they don't form properly. They remain narrow and stiff, hence reducing the blood flow from the mother to the baby. So because the blood vessels are too narrow, the placenta does not get enough blood. So when the placenta does not get enough blood, there is a release of harmful substances. So the poorly functioning placenta releases substances into the mother's bloodstream, and these substances damage the lining of the mother's blood vessel, which is the endothelial, causing endothelial dysfunction. So when these substances are released into the mother's bloodstream, the substances damage the lining of the mother's blood vessel. So once there's that damage of the mother's blood vessels, there's a widespread effect in the mother. So the blood vessels constrict, causing high blood pressure. The damaged blood vessels leak protein, which end up showing as a result in protein in urine, which manifests protein in urine. So the damaged blood vessels, they are damaged, so there is a leak in protein synthesis in the body. So when there's that leak in blood vessel being damaged, protein is then produced or released in urine, thereby being manifested as protein in urine, which we're calling proteinuria. So that was a general overview of the pathophysiology. So we now look at the clinical manifestations. So among the clinical manifestations, we have hypertension, or a blood pressure reading greater than 140/90 millimeters of mercury on 2 occasions of an interval of 4 hours apart. So we also have proteinuria, protein in urine, which is greater than 300 milligrams in 24 hours due to the glomerular filtration barrier, due to when there is a damage in the glomerular barrier. And then among the clinical manifestations, we also have a headache due to increased intracranial pressure. There is also visual disturbances because there is retinal edema. And then there's also epigastric pain, which is due to edema and also microhemorrhage. And then there's also generally edema on the face and on the hands. And then there's hyperreflexia. And then the diagnostic criteria, or what can make you diagnose to say really this is how preeclampsia looks like. So preeclampsia is a pregnant woman after 20th week of gestation whose blood pressure reading is above, greater or equal to 140/90 millimeters of mercury after the 20th week. And then protein in urine of which is showing urea in protein in urine, proteinuria during urinalysis, which is showing protein levels elevated beyond 300 milligrams, beyond 300 milligrams in a period of 24 hours, or which may also be absent. And then there is thrombocytopenia. There is also impaired liver function, where there is elevated liver enzymes. Then there is renal insufficiency, where there is creatinine of greater than 1.1 milligrams per deciliter. And then classifications of preeclampsia. So preeclampsia can be classified in 2 ways, and these are as follows. preeclampsia can present to be mild or severe. So mild preeclampsia is a type of preeclampsia with blood pressure readings greater than 140 over 90 but the readings don't go above 160 over 110 in mild preeclampsia. The ranges of blood pressure reading in mild preeclampsia is from 140 over 90 millimeters of mercury to 160. They don't exceed 100 to 160. When the blood pressure reading exceeds to 160 to 110, then this is referred to as severe preeclampsia. So in mild preeclampsia, the reading is 140 over 90, but it should be less than 160 over 110. So there is also proteinuria of greater than 300 milligrams per 24 hours, but it should also be less than 5 grams per 24 hours. And then in severe preeclampsia now, this is where we have blood pressure reading of above 160 to 110 milligrams of millimeters of mercury. So in severe preeclampsia, the blood pressure reading here now is 160 over 110 millimeters of mercury. And then there's also proteinuria, which is greater than 5 grams in 24 hours. So in severe preeclampsia, there are severe symptoms such as a severe headache, visual disturbances, and epigastric pain. And then medical management of preeclampsia. So when we're talking about the medical management of preeclampsia, we'll first start with the investigations. So among the investigations you will need to do is history taking. So under history taking, history will review history of having had preeclampsia in the family before. So another investigation done is physical examination. So physical examination, a head to toe physical examination will review generalized edema, and then you also assess the fetus. You do a fetal assessment where you do an ultrasound, you do a Doppler sound or Doppler study to assess the fetal well-being or the well-being of the fetus. And then you also do laboratory tests. You do urinalysis, which will review proteinuria, presence of protein in urine, which is greater than 300 millimeters of mercury. Yes, which will review protein which is greater than 300 milligrams. And then you will do FBC, which will review elevated amounts of platelets and hemocrits. And then you also do a liver function test, which will review elevated levels of liver enzymes. And then you also do a renal function test, which will review increased amounts of serum, creatinine, and uric acid. And then classifications of preeclampsia, we've got mild and severe, like we said earlier. So in mild preeclampsia, we monitor the blood pressure and proteinuria. So in mild preeclampsia, the patient's BP is usually between this is the diastolic pressure, blood pressure. It's usually between 90 to 99 millimeters of mercury, and the elevation is detected at least on 2 separate readings. And then in mild preeclampsia, there is proteinuria of 1 plus according to the readings on the mouth stick, and then to 2 plus. And then in mild preeclampsia, there is encouraged bed rest, and we encourage bed rest and reduction of activities. so as to reduce the blood pressure. And then we encourage frequent antenatal visits. And then in severe preeclampsia, the blood pressure reading exceeds 170 over 110 millimeters of mercury. And then in this case, the protein levels, or the protein levels in urine are greater than 3 plus or more, according to the readings on the mouth stick. And then in severe preeclampsia, there's also generalized edema, which may be present on physical examination. And then we look at the treatment. On the treatment, we've got medication or a group of drugs which we're calling antihypertensives. So under these antihypertensives, the drug of choices we have is hydralazine. So hydralazine is given 5 milligrams IV, which is given also intramuscularly. So when it's given IV, we give 5 milligrams. And then when it's given IM intramuscularly, we give 12.5 milligrams. And then we also give nifedipine 5 milligrams orally. We also give magnesium sulfate. So magnesium sulfate is given as a loading dose of 4 milligrams IV slowly over a period of 5 minutes. Or it can also be given as magnesium sulfate 50% solution, and it can be given IM, which is intramuscularly. So when it's given intramuscularly, you give 5 grams intramuscularly on each buttock, and it should be given with 2% of lignocaine. So magnesium sulfate, this is a drug we're also giving, as earlier stated. So the purpose of magnesium sulfate therapy is to prevent eclampsia, which presents with seizures. So we are giving magnesium in preeclampsia as prophylaxis, so as to prevent eclampsia, which presents with seizures. So the dosage for magnesium sulfate, the loading dose as earlier stated, is 4 grams when giving IV. Should be given within 15 to 20 minutes. Then the maintenance dose is 1 to 2 grams, which is given hourly via IV infusion. And then when giving magnesium sulfate, these are the things we need to put in place or keep in mind. You need to monitor the tendon flexion. You also need to monitor the respiratory rate. You need to monitor the urine output. And then that was our nursing management. So apart from the nursing management, we now look at the care we're going to give this patient. So the nursing care, we're going to monitor the blood pressure, the urine output, the reflexes. We're also going to administer medication as prescribed. We're going to monitor signs and symptoms of eclampsia, which are seizures, and then provide emotional support or psychological care, educate the patient on warning signs and complications, and then prepare for possible delivery. And then some of the complications which may arise due to preeclampsia. One, we've got eclampsia. So eclampsia is a severe case of preeclampsia. So in eclampsia, there is also presence of seizures apart from the elevated blood pressure and the proteinuria. But with preeclampsia, there are also seizures. In eclampsia, there are also seizures. So when preeclampsia is not managed, it leads to eclampsia, where now there's presence of seizures. So another complication is also what we're calling HELLP syndrome, which means hemolysis, elevated liver enzymes, and low platelets. And then we've got placenta abruption, where the placenta detaches. And then we've got disseminated intravascular coagulation. We've got fetal growth restriction, where the fetus is restricted to grow. And then we've got preterm delivery or preterm birth. And then nursing management. So in nursing management, we will start with our M's always. So our M's, we will write the 2 M's. Will ensure fetal well-being and prevent complications. Prevent progression of eclampsia as our M. And then we'll start with environment. We'll talk about where we're nursing this patient. So we'll discuss on environment. You will say, I will provide a quiet and calm setting to reduce stress, as stress can increase blood pressure. I will minimize noise and light in the patient's room to prevent cerebral nervous system stimulation, as bright light and noise may stimulate seizures. I also ensure the patient is nursed in a clean room to prevent spread of nosocomial infections. I will nurse the patient in acute bay for easy observation. And then you talk about the psychological care. I will offer emotional support or psychological care to the patient so as to allay anxiety, which is common in preeclampsia. And then I will provide education, educate the patient and reassure the patient about their condition, and explain the treatment plan so as to promote compliance and reduce fear. And then we also say I will actively listen to the patient's concerns and answer the questions asked by the patient honestly and supportively. And then you also say I will involve the patient's family in the patient's care and provide additional emotional support. And then you move to the next point, which is positioning. So you say I will encourage the patient to lie in the left lateral position to improve utero-placenta flow and decrease pressure on the inferior vena cava. So the patient has to lie in the left lateral position as advised, so that there is decreased pressure on the inferior vena cava. So I will avoid placing the patient in supine position to prevent vena cava compression and ensure adequate placental perfusion. So the next point we'll say is I will use a pillow to support the patient in a comfortable side laying position, ensuring proper alignment and comfort. We also say I will assist the patient to change position regularly to promote blood circulation or oxygen perfusion. And then the next point would be rest, which is very much encouraged. So you say I will encourage bed rest to reduce activities which will help lower blood pressure and improve utero-placental flow, which by utero-placental flow we mean blood flow from the mother to the baby, from the uterus to the placenta. So this is what we're calling utero-placental flow. So you also say I will establish a quiet hours during the day to promote periods of uninterrupted rest. So you also say I will promote or provide comfort measures such as additional pillows or back wrap to enhance relaxation and rest. You also say I will promote sleep hygiene by dimming lights and reducing nighttime disturbances to help the patient get adequate rest. And then the next heading is on nutrition. I will monitor the patient's dietary intake to ensure a balanced diet with adequate protein to support maternal and fetal health. So the next point is talking about I will advise the patient to limit sodium intake to help manage blood pressure effectively, as sodium intake increases the amount of water in the patient's body, which in turn add to elevated blood pressure levels. So I would advise the patient to limit sodium intake so as to help them manage the blood pressure effectively. And then you also talk about monitoring. So I will monitor the fluid intake closely to ensure hydration. And remember, as we monitor the fluid intake, we are trying to prevent this patient from also being dehydrated. So I will monitor the fluid intake closely to ensure hydration without overloading the patient's fluid in the body, which could worsen symptoms as lying to preeclampsia. So we want to hydrate this patient, but we do not want to ensure that to have cases of fluid overload, as fluid overload can only worsen this patient's condition. So we monitor the fluid intake. So we also encourage the patient to eat small frequent meals to maintain energy levels and manage nausea. Then you also talk about fetal well-being. I will monitor the fetal movement and advise the patient to report any reduction in fetal movement immediately. I will arrange for periodic ultrasound to monitor the fetal growth and assess amniotic fluid. So we also assess the baby's the fetal well-being of the child, of the unborn baby. And then another heading is observation. So observation, we're now doing observation on the mother now. So where we're going to say I will monitor maternal vital signs frequently, including blood pressure, heart rate, respiration or respiratory rate, and as well as temperature. I will measure urine output accurately to detect any signs of oliguria, which is little or no urine. So I will measure urine output accurately to detect any signs of oliguria. So oliguria means little or no urine, which could indicate kidney problems or kidney involvement or kidney malfunctioning. So I will test for proteinuria using a diagnostic test we're calling urinalysis. So I will perform urinalysis test for proteinuria using dipstick tests for in 24 hours of urine sample which has been collected, so as to monitor the disease progression, to check if the amount of protein contained in urine in 24 hours, whether it's increasing or whether it's decreasing. So you perform urinalysis on this patient every day to measure the amount of protein in the urine within 24 hours. So you do observations to see the amount of protein in urine. And then I will also assess the neurological symptoms. So neurological symptoms such as headache, visual disturbances, hyperreflexia, which may indicate worsening preeclampsia, or which may indicate signs of severe preeclampsia. And then in summary, in today's lesson, we've discussed that preeclampsia, this is hypertension which presents with proteinuria in a pregnant woman after 20 weeks of gestation. And then we also said early detection and management of preeclampsia are crucial. Severe cases require hospitalization, like we earlier stated, while mild cases do not require hospitalization. So nurses or nursing care plays a vital role in monitoring patients' education. So those are references. And then if you've got any question regarding preeclampsia or in line with today's discussion, or any other topic, or any other topics you want to see in future, you can comment in our comment section below. And then today we discuss preeclampsia, and I am your presenter, Nessa's Diary. Thank you for attending our lesson. So if you like the video, I would advise you subscribe to our YouTube channel, and don't forget to subscribe to Nessa's Diary on the link below, on the red caption below. You can subscribe to get more videos like this, and be updated each time we drop new videos. And then don't forget to stay tuned. God bless you.